Hello everybody. This is a continuation of part 1 neurological disorder, and we're going to talk about the convulsive or convulsions or seizure. Okay, in today's video, what are the convulsive disorder and the seizure? These are abnormal motor activity or any alteration on the sensation, perception, changes, and motor activity of the client. So there is a paroxysmal seizure with or without loss of consciousness. Okay, now what's going on in here? Now, remember the brain has a lot of electrical activity and need to be coordinated from the brain. And therefore, if not, there are electrical disturbances that's happening from the brain and then to the nerve cells on different parts of our body. Then therefore, it emits excessive electrical impulses that cannot be controlled by our body, specifically our brain. Okay, it cannot be interpreted by the brain, so there are paroxysmal seizure activity. Now, how can we get this? We could get it easily. Just follow the following, okay? These are the things that you could do. If there is a head injury or birth trauma, you would have to get it, okay? That's idiopathic or unknown. It's unknown, remember that. Or you could have toxicity of carbon monoxide. This is easy to get. Just leave on the air conditioned room or to your car. You will get a seizure. Okay, genetics, so it means like it runs in the family, so we cannot get it, so we cannot change it. Okay, or sudden withdrawal to anticonvulsants. Remember, this would not be abruptly stopped. They need to be like slowly and surely, okay? Physical stress, of course, just try to go back and forth on the heat, and if your body cannot longer hold it, then you're gonna have the seizure eventually because the brain is decreasing glucose and oxygenation, okay? As well as nutritional and metabolic deficit. Those who are not sleeping, focus on their gadgets 24 hours a day, it's easy to get a seizure, okay? And of course, brain tumor, if you're exposed to a lot of chemicals or chemotoxic agents, so you would have to get that easily. So these are the possible causes. Just follow the step to have seizure. Okay, next, what are the signs and symptoms? So we focus on the classification of the symptoms itself. There are many ways or types of your seizure. Generalized seizure, example are your grandma or the tonic and clonic seizure. Now, these are commonly seen with a client who has symmetrical extension of the extremities with or without an aura. Okay. Epigastric pain, the client with an epigastric pain or loss of consciousness, and the client have post-ictal sleep as well. Okay, so these are grandma clonic tonic. So it will start with flexing of the extremity or your decorticate posture, and then will extend, and then the client would have seizure. That is decerebrate posturing then. Now, next is the petimal, or the petimal is common in children, wherein it will look at you, blank stare, as if like they were looking at somewhere far, and then decreased blinking of the eye, it will not blink, and then twitching of the side of your lips. Then the client would have loss of consciousness 5 to 10 seconds after that. So that's a petimal. Remember, if they ask you seizure in children, that's your petimal. Blank stare, twitching of the side of the mouth, okay, and no blinking, and then the client would have loss of consciousness, petimal. It's a good name for your kids. Come on, petimal, come here. Next, just kidding. Okay, so this is an example of the tonic phase, wherein there is the corticate posturing, and the clonic phase would have decerebrate posturing. Okay, that's the clonic phase. Okay, next, localized or partial seizures. So Jacksonian or focal seizure are like a tingling or jerky movement of the index finger or thumb. So that would spread like onto one side of like a Michael Jackson, okay, Jacksonian or focal seizure. Then psychomotor or focal motor seizure are automatic, clouding of consciousness or hallucination. This could be seen commonly with some other disorders, like for kids who had like cerebral palsy. So those who have that kind of condition, usually they have this psychomotor or focal motor seizure, okay? Then the worst one is the status epilepticus, wherein this is continuous, uninterrupted seizure activity. If untreated, the client would have comatose or death. So eventually, I've seen clients like this that continuously they have like 5-10 minutes of seizure and the brain will die and the client have comatose. And now the effect of this is very damaging to the brain. It will lose some motor activity, so like paralyzed at all, okay? Now, nursing intervention is very important. We have to focus. During the seizure, what we can do is remove any harmful object from the side or surroundings of the client, because during the seizure, it might hit things that could hurt them. Check on that. Remember that. Ease the client to the floor. Okay, protect the head with a pillow or something that is soft to the head. Okay, then do not restrain the client during the seizure. Okay, the big no-no. Observe, note the duration, parts of the body affected, so we could classify what kind of seizure that, or any behavior before and after the seizure. Usually when there is an aura, like they will shout, the behavior changes or something, okay? We need to note on that, okay? Now, during the seizure, loosen the constrictive clothing to the client and do not restrain, I told you, okay? Or attempt to place anything on the mouth, okay? Or anything that, or insert on the airway, because there's a tendency that they could swallow it and block the airway. So do not do that. Now, during post-seizure, what we're gonna do, okay, place the client to the side to drain any secretions to prevent aspiration. So remember that, okay? Help the client to reorient. Hey, you're here in the hospital, okay? So something like that. So reorient the patient. If confused, usually they have confusion because of the post-ictal sleep, okay? And if they get incontinent, they pee, they poop, we have to take care of that too as well, okay? Because like violent contraction of the muscle, so include your bladder would pee and then you would poop, okay? Stress importance of the medication regimen. Remember that anticonvulsants are not abruptly stopped, okay? So they have to give schedule of lowering the dose or anything like that, okay? Medications given to the client these are the common, the Dilantin or the phenytoin, but there are side effects of that. Gana, what are gana? The client have the gingival hyperplasia or like thickening of the gums, so we have to have meticulous oral care to the clients. Mouthwash, okay, toothbrush. The client would have the hairy tongue. It look like a hair, but there is like a block thing that is developing on the tongue, okay? That's called the hirsutism. The client would have A-taxia or incoordinated movement, sometimes like tick or movement of the hand, tremors or something. Nystagmus, the client would have nystagmus. Nystagmus is like the rolling of the eyeball, okay, like exorcism, like rolling of the eyeball. And the client would have fever most of the time, so they give acetaminophen, okay? Now, Tegretol or carbamazepine are also given, but they have to be careful that this would cause arrhythmia, okay? And the phenobarbital is also given, or Luminal, but it is a CNS depressant. You will feel like relaxed and dizzy, so avoid driving, avoid heavy operational activities. So that's what we gave to the client. That ends for the convulsive or seizure. I hope you learned from that. Okay, list down the lecture so you could have more ideas. If you want to add or comment, please comment down below. And that'll be all for today. Thank you, and God bless us all.